Welcome to the Nickman Drug Show. Once again, I'm joined by my friend, my new friend, who I'm learning so much about and so much with, Pete Krekel. He's a pharmacist for Nickman's Drug. He's the director of their clinical services. That might not sound like much, but when you realize how big and how vast Nickman's is and all the stuff that Pete gets into, it's quite a lot. This guy has 44 years of experience, and we're just kind of getting started. This is our second show. I'm excited to have you once again. Pete, how you doing today?
I am doing splendidly today. I'm really enjoying this opportunity to reach out to all of our people in the world of WMBS.
Yeah, absolutely. I'm excited to have you. It's great to have somebody who has the knowledge, but also kind of has the personality like you do. You're no stranger to sharing your thoughts and just chatting.
That is correct. And maybe after 44 years of marriage, I'm pretty good at knowing when not to share my thoughts and when to chat.
I gotcha. And as Pete shared with us in our first episode, if you didn't catch it last time, he has been, like I said, a pharmacist for 44 years. His wife is also a pharmacist. His daughter is a pharmacist. His son-in-law is a pharmacist. His boss is a pharmacist. There's pharmacists all over the place. He knows a myriad of folks and knows a little bit about a lot of things. A generalist.
Yes, we'll call him a generalist.
Yeah, a little bit about a lot of things.
This deep, but this wide.
That's it. That's what I wanted to see.
This deep and that wide.
So today we're going to be specifically talking about pharmacist relationships and insurance plans. So I know that one of the things you and I had chatted about already is the importance of that relationship with your pharmacist. And then also how that translates into the connection with the insurance plans too.
Exactly. And unfortunately, the two can't be separated. What happens so often is we can establish a great relationship with a patient, but then if they sign up for an insurance plan that they have to move somewhere else. And the insurance companies are sneaky. Let's be realistic. They're not going to say, oh, Josh, you can't come to Pete's drugstore anymore. Josh, if you go to Pete's drugstore, your copay is going to be $35. But if you go to XYZ or any other three-letter drugstore name, your copay will be zero.
Yeah.
So you can see the how they can muscle you into doing that.
Right.
And that's why this is just such an important topic, is to interact with your pharmacist and the pharmacist interaction with you, because we know you. We know who you are. You know, our kids might have been in band together. Our kids might have gone to school together. And we develop these relationships over the years, only to sometimes have them torn apart by the insurance companies. So I'm not really a good friend of the insurance companies. I would have to say I can be a real pain in the neck with them. And
and that's the clean version.
Yes, exactly. We could use some other anatomical features, but it wouldn't be appropriate on WMBS. So let's get talking about this relationship. The first job I ever had, I was up in Clearfield, Pennsylvania, at a Rite Aid, my first job out of school. And the store was getting busier and busier, and I needed more pharmacy technician help. So I reached out to my boss, the district representative, my boss, and I said, we're just getting buried here. And I said, the paperwork's incredible. I need some more help. And he looked at me and said, I've watched you work, Pete. And he said, if you quit talking to those patients so much, I think I shut him down then. But if you stop talking to those patients so much, you'll have plenty of time to do our store manager weekly report, the infamous SMWR. And it was a Saturday afternoon thing that took 2 or 3 hours to complete. And went home that night, said to my wife, I made a bad decision going into pharmacy school. And so I thought maybe I'd go to Pitt, pick up a PhD and teach. Ended up at Cop Drug Store in central Pennsylvania, where for 26 years I got to practice just exactly how I wanted to. We lived in Tyrone. We developed wonderful relationships with the doctors and of course the patients and the community as a whole. And saw he was going to be selling to Rite Aid, so left there and ended up at Thompson Pharmacy in Altoona, worked there for 12 years, worked in a doctor's office a couple of days a week, and again, developed relationships with people.
Right.
And that's what is just so critical to do, as a pharmacist. Unfortunately, with the massive amounts of data and paperwork and now immunizations and things like that, it's harder and harder for our pharmacists to really reach out and get to know their patients and truly get to talk to them. I'm kind of an anomaly with that. I am very, very much semi-retired. My wife says you're retired, you're just not real good at it.
Okay.
And so I don't dispense a whole lot today, but I've always been an advocate for my patients. Well, the one thing that with fighting insurance companies that comes to mind, we were being severely under-reimbursed for Narcan when we were dispensing it. And we're going to talk a whole lot about Narcan later on, but in an upcoming episode. And losing money on it. We were losing like $2 or $3, and it was through a couple of the health insurance plans in Pittsburgh. And so I reached out to them, made some noise. They ignore your call every time. So I got my state representatives at that time to get on board with me, and did they get on board? I got a call, and it was like, okay, what can we do? So they raised our dispensing fee enough so that we made 75 cents.
But it still flipped it.
Right. They knew that it would cost a couple cents to shut me up, and they spend it.
Yeah.
So that's what they did. Instead of losing like $3 or $4, it was now to the positive. So we as pharmacists could dispense this life-saving drug that we're going to talk a whole lot about.
Right, without being a loss for the pharmacy.
Right,
Yeah.
exactly. And I kept screaming and said, you people are telling us we need to dispense this naloxone, this Narcan, to our patients that are at risk. But we're losing money on it. For some people, and we'll talk about stigma later too. We're going to talk a lot, Josh. And, we talk about the stigma of this. And I said, once I get pharmacists convinced, then they say to me, no, I'm losing money on it. Thanks, Crackle. And so then again, we have to work better with our insurance companies who are just impossible.
Yeah.
So we're going to talk a whole lot about them. So let's talk about insurance.
Yes.
What is insurance? I know it's $185, but my insurance company paid for it, so it's good. It's like, no, it's not.
Yeah.
And I'll tell you why. Insurance is a pot of money, and we all throw handfuls and big handfuls of money into this pot, and somebody else passes that money out of the pot.
Right.
It's not the insurance company's money, it's our money.
Right.
And so the higher the drug prices are, the more money gets pulled out of the pot, which means I have to put more money into the pot. And that's what insurance is. It's trying to level the risk. So let me ask you a question, Josh. I'm going to get really personal with you.
Okay.
Do you have car insurance?
Yes, I do.
Yes, you do. And what does it cover? Does it cover windshield wiper blades?
It does not.
Does it cover headlights?
No.
Oil changes?
No.
Tires?
No.
Why not?
That's a good question.
Because
I wish it did.
They're all expenses that we expect to incur.
Correct.
Over normal wear and tear, whether it's our bodies.
Correct.
Or whether it's
General
Josh's
upkeep,
car.
yeah.
Yeah, exactly. Stuff that we know. Well, the problem has now become the exact opposite. The insurance covers everything, and when they cover it, it's a whole lot more expensive.
Okay.
And we'll see this just even in our drug company prices here. I am not a proponent of national health insurance. Okay, and the reason for that is until they can learn to run a post office, I don't want them touching my health care.
Understood.
So, but they have touched my health care because now that I'm on Medicare. So let's start talking about Medicare. I'm going to need the reading glasses just so I can give you some numbers on this. So insurance and Medicare, as you can tell by this luscious gray hair I have, I am 67 years old, and let's talk about Medicare. The national health expenditure grew 7.5% to $4.9 trillion in 2023, or it grew an average of $14,570 per person.
That seems disproportionate. That seems out of whack.
Josh, did you get we're not going to pick on your staff here at
Okay.
WNBC, especially your fine station manager, but did you get a 7.5% increase or a $14,570 increase?
I think he would have given me one if I. No, I didn't. I didn't.
Medicare spending grew 8.1%. You didn't get an 8.1% either, did you?
I did not.
Or to 1.029 billion, okay?
No.
Which is 21% of the total national health expenditure. So it's me and my homies, over 65,
Yeah.
are the ones that are accounting for 21% of the national health expenditure. Medicare spending grew 7.9%. What's inflation?
Wow.
3-4% of
That's
that.
yeah.
Okay, to 871 billion, or 18% of the total national health expenditure. Private health insurance, it's gone up too. It's gone up 11.5%, which is the reason why so many companies are just getting strangled
Yes.
by these rising healthcare costs. And I think in the old days it was, well, I get health insurance, I get Blue Cross as a benefit. My dad was a welder at the paper mill up in Johnsonburg, and in 1955, they had to keep their really good welders. Well, they couldn't give them raises because of the wage freezes after World War II, so they would give you health insurance. They would give you fringe benefits like that.
Yeah.
When I was born at the hospital in St. Mary's, my bill my mother saved it was $55 for me.
Wow.
Okay, and it's not because I was like
You weren't
in
like the
defective
you weren't the
product.
reduced rate
Yeah,
baby,
reduced-
right? Yeah.
reduced- yeah. This kid, he's got quite a few things wrong with him. He talks all the time, but other than that, I think you're going to be able to take care of it.
Right, right.
So because of that, I was $55. Today, what do you get for $55? Probably a Tylenol in the hospital.
Right.
So these things have just grown out of proportion. And we can't blame the hospitals for this because it's everything else has contributed to it. Hospital expenditures grew 10.4%. Physician and clinical services grew to 7.4%. To almost $1 trillion in 2023. And prescription drug spending that we battle every day increased 11.4% to $449 billion, which is faster than the 7.8%. It grew from 7.8% in 2022. Then on top of that, in 2023, add another 11.4%.
So almost 20% across 2 years.
Exactly.
Wow.
Do you see why?
I see a lot of problems there.
A lot of problems there. And who do we blame? It's everybody's fault. We want to blame the doctors because they might drive a nicer car than me. I drive a Honda Civic, so I'm okay. But these are all things, a lot of it is the drug companies, and I don't hold back on them because that's what's nearest and dearest to me. I really don't know what suture material in the operating room costs,
Right.
but I can tell you what Ozempic costs. And everybody loves Ozempic. We're talking Ozempic about putting it in the water, basically, except you have to inject it. Ozempic costs, when Jim Nickman buys one from our wholesaler, it's $997 for 1 month. That's what it costs him. Okay. My son lives over in Germany now. He lives in Frankfurt, and we went to his pharmacy there, and I talked to the pharmacist there, and a very, very smart, astute woman. And I said, everybody's using Ozempic in our country. I said, we pay close to $1,000 for Ozempic. What do you guys pay for it? And she says, not that much. She said, 80 euro. And because my German isn't that good, I only speak English, and she didn't understand my sarcasm. And I said, "Oh, you've got to be kidding." And she said, "I am not kidding."
Yeah.
And she turned the computer screen, pointed to me, and she showed me where it was 80 euros or $86. The very same medication that costs Germany $86, Jim Nickman will spend $997. My goal is to figure out a suitcase with a cooler in it that I can sneak past TSA and bring a couple cartloads of Ozempic over. But
Wow.
Ursula told me she can't even get it over there because they have to buy 12 of them for every one that we do. That's 12 times more expensive in the United States than over there. Josh, nobody can rationalize that.
No, that's hard to fathom. I want to keep talking more about this. I'm going to let everybody know who we are, just in case you're just joining us. You're listening to WMBS 590 AM 101.1 FM. If you're joining us online, welcome. I'm here with Pete Krekel. He's the Director of Clinical Services at Nickman's Drug. This is our second show, and we are into some really fascinating stuff. Pete's talking all about health insurance, your relationship with your pharmacist, and we're talking about right this moment Ozempic and just some of the differences that we see out there. And Ozempic is just an example.
Right.
I imagine this happens with other things as well.
It happens all the way across the board. Insulin was a big deal as well. And when I think about it, the Ozempic is actually made by Novo Nordisk, which is a Danish company. It's not just an American company.
Yeah.
The guys across the pond know that who they can put the screws to.
Mm-hmm.
And so it is. It's very much a problem with all of the drugs. If you can pronounce the name of the drug, it's probably too expensive.
Wow.
Now, if you can say things like irbesartan, that's kind of hard to say. Avapro, that's the brand name. So, and brands and generics, this is a thing too. Are really interchangeable. We get this question a lot. It's probably my most asked question as far as pharmacist, patient. Is a generic really just as good? You know, we might go to the grocery store and we buy our Libby's pineapple, because when my wife makes her Waikiki meatballs, she wants Libby's pineapple. She doesn't want the generic ones because she doesn't think that the product looks the same or is it as good or whatever. That's not the same with drugs. They have to be the same.
Yeah.
The FDA requires them to be the same. And you're looking at a guy who back in 1992 said, there are 4 drugs a pharmacist should never substitute: Synthroid, Lanoxin, Dilantin, and Coumadin. They should never be substituted. And I'm telling you today, you go to any pharmacy in the United States, you will not find brand name Synthroid, brand name Coumadin, brand name Dilantin, because those drugs themselves are available generically. They're just as effective. We can monitor it with blood levels. So that's what we use. And the price difference is incredible. This morning I was teaching about heart failure to the PA program up at Pitt. And we talked about Lanoxin. Comes from the foxglove plant. And that drug back in 1981, when I was working as a new pharmacist, we were charging $1.89 for 30 tablets of brand name Lanoxin. There would be no generics because the price was reasonable. Well, as the price went up and up and up, they started making the generics. They only have 17 years of patent life, but because they kept the price so low, it wasn't lucrative to make a generic. So as the prices climbed and climbed, today a bottle of 100 digoxin, Lanoxin that I looked at was close to $1,200 for brand name. So it went from $1.89 to 30, let's say $6 up to $1,200.
How? Why?
right. Exactly.
I mean, those are the $1 million questions.
Yeah, exactly. And those are the problems. So when people rejoice and say, well, this should have cost, $800, but my insurance paid for it. That's $800 that your boss could have used to increase your salary.
It's all still coming out of somewhere.
There is no free lunch, I think, is the best way to say it.
Yeah.
Even when a drug company brings it to you.
So I know that we're talking about insurance. This is maybe a little bit off. So a question I guarantee you that some of our listeners might be interested in. You said no difference with generics. Is that the same for OTC stuff? Like Tylenol, Advil, are they as good as acetaminophen and ibuprofen that is
Identical.
generic?
They're all the same. They have to meet the same FDA requirements for inspections and everything else.
So it's almost like a placebo at that point. If you're buying when you're buying, when you want to say I have to have Advil, you could actually just buy the generic ibuprofen.
Exactly.
Yeah.
Exactly. And those are the things that we answer a whole lot. I think people are kind of getting onto it. And the truth is, today, I would say 10%, maybe 15% of what we dispense is brand name. And the other 85% is generic. People can't wait for it. One of the psych drugs that we dispensed, Latuda, was about $1,200 a month it was. And today the generic, I think is around $6 or $8
Wow.
a month is what Jim pays
Wow.
for it. And I sit on Pennsylvania's Pharmacy and Therapeutics Committee,
Okay.
and which determines all of the drugs that are covered first line for the Department of Public Welfare. And matter of fact, our meetings are in September, and so in preparing for them, I'm reading all this stuff over, and we just can't be irresponsible because now we're looking at taxpayers' monies. And we go back and forth on some of them. We want the very best drug for the patient, but sometimes we just have to kind of wait for it to go generically, and Latuda was one of them. I remember initially I fought for it because it's probably one of the safer drugs for pregnancy, and I said, well, we don't want a pregnant lady to be untreated while she's trying a drug that might not be as good in pregnancy and all, before they do the prior authorizations. And it didn't go through, but now they would. So it is a challenge. There are select populations that need certain medications that are a lot more expensive, but by far and away, everything in my medicine cabinet, it's generic.
Yeah, that's really good, and it's a good tip for our listeners and viewers, especially with that OTC stuff, and also to discuss with your physician as well. If you have an opportunity to go generic, sounds like you can save yourself some money.
I do. And I
Yeah.
take all of my stuff generically as well. So as far as Medicare goes, which that's me, I'm an old guy, and this program's about me, right? And we do have an elderly population. So what is Medicare? Okay, I am a card-carrying Medicare member. The most important health insurance document I have is on a piece of paper. Little white piece of paper card. And so I have that in my wallet, of course. And Medicare, there's lots of Medicares. It's alphabet soup. Medicare A is your hospitals.
Okay.
Okay, so Medicare A is your hospital insurance, and heaven forbid I end up, in the hospital. Medicare is what they're going to start with. So there's a deductible for Part A. It's around $1,632. So that's Medicare A.
Okay.
Medicare B is the doctor and other health services. We do a lot of Medicare B billing at Nickman's, like for the test strips.
Okay.
We did a lot of Medicare B billing for COVID shots, and a lot of our immunizations are billed on Medicare B. Medicare D is drugs, okay? And Medicare D is the one people switch plans like a fair amount based on what's covered. The good news with Medicare D is they're all amortized equally bad. Okay.
Okay.
When Medicare D came out in 2006, I knew that we'd be a whole lot busier and we'd be filling a lot more prescriptions because virtually everyone over 65 would have prescription insurance. Up until then, it was the PACE program is all that we had in Pennsylvania that was funded by the lottery. So this all becomes a political game. And Dick Thornburg, you remember Governor Thornburg?
I do.
Sure, great guy. He was on the spillway of the dam up in Tyrone in 1983, and they were just launching the PACE program, and at the time they had a $4 program through Blue Cross of Western PA. You paid $4. Well, Blue Cross said, this is unsustainable, so they eventually canceled the program. So PACE stepped in with this lottery-funded program, and they came in with a $4 copay. And I talked to Governor Thornburg, and I said, I'm glad we're taking care of the senior citizens in Pennsylvania. I says, but Governor Thornburg, with all due respect, if Blue Cross can't make it work, how are you going to? He said, I understand your concern. He said, but within 3 years, the copays will be about $20 and not $4. Well, about 8 years later, Governor Casey office decided that they needed to raise these copays because they kept losing money. So they raised it to $6. It went from 4 to 6. And every political opponent, he raised your copay 50%. Now you can't vote for him. You got to vote for me because I won't raise your copays 50%. And so it's a political ball. The PACE deductibles today are they're $8 and $12. Okay, and then there's a PACE Net which is $15. So it's 6, 8. Yeah, PACE Net's 8 and $15, and then 6 and $10. So the deductibles aren't anywhere near the $20 that Governor Thornburg said.
Yeah.
So, but what they've done, though, because we would rather lose one vote than a whole block of votes, they just don't raise the income level, so they pick you off one at a time, and that's what happens to our patients as well.
So it's on the other end. They're doing it on the other end. It's still happening.
It's still happening. They're still eliminating patients, but we don't want anybody to say, you raised our copays 50%, we're voting you out of office.
Right.
So, and that's the fun part of insurance. It's history. It's always been sharing the risk. The earliest known insurance plans were in the 1870s. And what they did was the railroad, guess what? If Josh falls off of a train and breaks his arm, we need to get him medical help. So they built a lot of hospitals. A lot of the railroads did. The Pennsylvania Railroad built Altoona Hospital because up until then it was pretty much your religious organizations, like the Mercy Hospitals and the Presbyterian Hospitals, places like that built the hospitals. So, but it was the coal mines, which we have around here plenty of, as well as the lumber companies, and the railroads were really initially responsible for it. In 1929, Blue Shield was started as an experiment at Baylor University. For $3 a semester, you could have health insurance coverage, or $6 a year, you could get up to 3 weeks coverage in their hospital. So that's kind of how this all started. And then with the Depression coming on, you had more and more hospitals and groups starting similar funding.
Yeah.
Now the problem is today, what if I don't have insurance? Well, there is a law on the books that the hospital must take care of you. Okay? If you go into an emergency room for whatever reason, whatever ailment, the hospital by law has to take care of you. And that, again, is very, 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 very expensive. Because let's say you had a splinter in your hand that you just couldn't get out. Well, maybe if you could go to an urgent care and have a PA pull that out for you, it might be costing $60. But if you don't have $60, now you go to the emergency room, wait there, and have all of that. That might be a $2,000 procedure that nobody's going to pay for.
Right.
So you can see the challenges that we have today in healthcare is this disconnect.
Yeah.
It's this disconnect between medicine and pharmacy is the big one. Because like in the world I play in, there's a drug called Entresto. It's for heart failure. Amazing drug. Saves lives, keeps people alive longer, but it's expensive. So if the company that's doing your Medicare D comes along and says, we're not going to pay for Entresto, and I go into acute heart failure, end up in the hospital, it's no skin off of the Medicare D company's nose because they don't pay for that.
Yeah.
If it was all together as one where we can give you good therapy and keep you out of the hospital, and both receive the financial rewards of that. Because right now, the most expensive healthcare is in a hospital.
Yeah.
And if we can keep you out of it, all of a sudden, a couple $100 a month to the drugstore, it's really a bargain.
Yeah. Pete, this is fascinating stuff. I could literally talk about this stuff with you forever, but we're already out of time. This show just flies by. You're filled with knowledge. This is Pete Krekel. If you're just jumping on, he's the director of clinical services. He's the pharmacist at Nickman's Drug. This is his show. We're happy to come and join you and talk about healthcare issues. Pete is an expert. He's got 44 years in the business. Pete, it's my pleasure to host you once again today.
Oh, thank you very much, and look forward to our next.
Yes, sir. Okay. Take care, everybody.